Okay, I think we're on air. So, good evening, everyone. I'm Edith Schussler, and I'm an assistant professor at Weill Cornell. I have the great pleasure of moderating the first case this evening, which is going to be presented by Dr. Arjola Cosper, who is a current fellow at Montefiore Medical Center, Albert Einstein. She will be presenting a case of immunodeficiency, primary versus secondary. And her mentor is Dr. Manish Ramesh, who is an assistant professor at Montefiore, who was a fellow at Mount Sinai before I was. And then we have the great pleasure of having Dr. Charlotte Cunningham-Rundles as the senior mentor for this case. Charlotte was a mentor actually to both Manish and myself when we were fellows. She's the Gottesman Professor of Immunology at Mount Sinai. She's a professor of medicine. Her accolades go, there's so many, so I'm not going to tell you all of them, and I think everybody knows her pretty well, but she's absolutely an expert in immunodeficiency and especially antibody deficiencies and CVID, and we're really happy to have her with us tonight to help with the presentation of this and for the discussion. Oh, one more thing before you get started. So attendees, there's an attendee chat, and as we go along, if you have questions, please post in the attendee chat, and we will stop periodically to look at the questions and ask the presenters. So Dr. Cosper, it's all yours.
Okay, great. Hi, everyone. This is Arjola. I'm one of the fellows. Thank you for that pleasant introduction. I'm going to get started. Okay, so our case today, our patient today presented with a chief complaint of recurrent infections. She's a 29-year-old female with rheumatoid arthritis, developmental delays, presenting with a history of recurrent infections. We had limited history by the patient and the mom that was there with her, and we had no prior records that were provided to us, but to the best that we could obtain on that day, they stated that she had had about 8 total pneumonias, 2 of them requiring ICU admissions. One was secondary to sepsis, and the other one due to chest tube placement, and this all occurred in the last 3 years. They reported boils under patient's arms that were treated with warm compresses and oral antibiotics. She stated she had recurrent strep every 3 to 4 months, recurrent bacterial conjunctivitis, abdominal abscess. There was one episode of this, and this required drainage. And she also complained of recurrent oral sores. So past medical history, about 3 years prior to presentation, patient had been diagnosed with rheumatoid arthritis. They stated that initially she was on Humira for a few months. They weren't quite sure exactly how long, but then she was eventually switched to Xeljanz for better symptom control. And she was on Xeljanz for approximately a year and a half, and then stopped Xeljanz for 6 months prior to presentation to our clinic due to concern from family that patient was being immunosuppressed, and this is why she kept getting sick all the time. Patient reported a history of asthma, controlled with just albuterol, no ICS, never been hospitalized. She did endorse developmental delays, had been receiving early intervention since age 1.5, and was diagnosed with mild retardation. Patient was evaluated also for aspiration. They were told that results were negative, but that further testing would need to be done to rule out the possibility of small aspiration. A year prior to presentation, she had a right hip replacement secondary to complications from rheumatoid arthritis. She was currently on vitamin B6, B12, Mobic, Plaquenil, and Levaquin. They did not endorse any known family history of autoimmunity or immunodeficiency. So on review of system, on the day of the visit, she had a cough, but was negative for shortness of breath. She did complain of joint swelling and myalgias, but she stated that was more or less her baseline. And then significant finding on her physical exam, she did have swelling of her ankles bilaterally, mild deformities of the wrists bilaterally. We appreciated small cervical adenopathy, small inguinal lymphadenopathy bilaterally as well. So I just wanted to remind everyone about Xeljanz. What is Xeljanz, otherwise known as tofacitinib? It's an oral JAK inhibitor for the treatment of rheumatoid arthritis. It's a targeted synthetic small molecule that works at the intracellular level. Tofacitinib is a reversible competitive inhibitor that binds to the adenosine triphosphate binding site in the catalytic cleft of the kinase domain of JAK. The structure of tofacitinib mimics that of ATP without the triphosphate group. As a result of binding to the ATP site, tofacitinib inhibits the phosphorylation and activation of JAK, thereby preventing the phosphorylation and activation of STATs and thus the activation of gene transcription. So the overall impact, decreased cytokine production and modulation of the immune response. And then this is just an image of what we just talked about. So before I go the next steps of what our initial assessment was and what our next step on the workup, I just wanted to see if there was any thoughts on differential. Okay, someone said, Elizabeth said hyper IgE. Dr. Resnick says Xeljanz also definitely caused the perforated large intestine. Okay, maybe that's why she had the abdominal abscess. Unmasking of primary immunodeficiency. Okay, thank you for participating. Primary due to JAK inhibitor. Okay. So our initial thoughts at the end of the visit was that this was a 20-year-old female with rheumatoid arthritis and recurrent infections while on immunosuppressant. Our differential diagnosis was primary versus secondary immunodeficiency versus recurrent aspiration, given this history that even though she was told she was negative, they still wanted to evaluate her further for aspirations. We advised mom to send further records to our office from prior hospitalizations and from her rheumatologist because we did get limited history. Our immune evaluation, we wanted to include cellular and humoral immunity evaluation in addition to neutrophil oxidative burst given history of skin abscesses. We wanted to obtain vaccine titers. We also wanted to look at her lung function. And then depending on those results, we would further consider genetic testing.
I'm going to hold you here for a second because there were a couple more comments and questions that came in. And one of them was for the audience, clarification of when she started the immunosuppressant versus when she started having the pneumonias and other infections, to clarify.
Yeah, so they're all in the same timeline. So she was diagnosed with rheumatoid arthritis 3 years prior to presentation. And within that 2.5 year period, mom reports all this pneumonias and skin abscess, the abdominal abscess, and also the skin abscesses. And hence why mom came to us with this convinced that, it's all this immunosuppression that's causing her infections, because prior to this, she felt like that was not her child.
Okay, sorry, I just wanted to clarify that for a couple of people that asked on that question.
Yeah.
Just to, this is Manish mentioned from the attending on the case, just to clarify a little bit more, most of the infections accelerated in the last year leading up to her referral. And it was infectious disease who was most alarmed by it and said that you need to see someone.
Okay, we could then move forward. Thank you.
Move forward. Thank you. So on our initial workup for primary immunodeficiency, We obtained a CBC, which was significant for eosinophilia, 1200. We obtained immunoglobulin levels which were low across the board. She had no protection to MMR, tetanus, or streptococcus pneumonia. Her strep pneumonia titers were all less than 0.3. And she had a normal neutrophil oxidative burst. And this should actually be in the next slide, but we did obtain a T-cell receptor gene rearrangement, which was monoclonal, and we only obtained that after we had already looked at the lymphocyte subsets, which I will show you in the next slide. The subsets were significant for an elevated CD3, CD4 count, and also CD18 count, but she had no B cells. Her mitogens were also impaired. So with those subsets, at that point is when we ordered also the T-cell receptor gene rearrangement. Concerned about the fact that she had the elevated CD4 count.
Did you have her previous rheum workup, or did you do any additional rheumatologic workup for her?
We did not do additional rheumatologic workup. We were told we'd be obtaining it, which we're still waiting on because we saw this patient right before the COVID pandemic hit and right before everything peaked and we all got deployed, but we did not obtain further rheum workup.
So there was no referral letter or anything that told you how they came to her RA diagnosis?
I don't believe so.
Okay. Oh, and another question.
She did not receive rituximab, Rachel. Okay, so then we also obtained PFT, which showed reduction in flow rate secondary to poor effort. They noted that there may be obstructive disease as there was air trapping. They noted mild restrictive disease. The diffusing capacity is moderately impaired. They noted that if the diffusing capacity could not be explained by anemia, it could suggest emphysema, interstitial lung disease, and pulmonary vascular disease, and they recommended clinical correlation. So then from this point on, we move forward with so just to kind of bring it back together, with the low immunoglobulins, the no protection to the vaccine titers, the impaired mitogen responses, the lack of B cells, and the monoclonal T-cell receptor gene rearrangement, we moved forward with an in vitro primary immunodeficiency panel, the CVID, and also the globulinemia panel, which resulted with 3 variants of unknown significance. The first one was the FIH1 gene, which is associated with autosomal dominant Aicardi-Goutieres syndrome and Singleton-Merton syndrome. So Aicardi-Goutieres syndrome, it usually presents much younger in life. They have neurological delays, which our patient does have. They also will have some features of autoimmunity. I read in literature reports of SLE-like features. The RMRP gene associated with autosomal recessive cartilage, hair hypoplasia, and exectic dysplasia. Again, not features seen in our patient. And then the UNC93 gene is associated with autosomal recessive susceptibility to herpes simplex encephalitis, not related to our patient, or at least with what she presented with. So that was the primary immunodeficiency workup, and I just want to go to discuss the possibility of secondary immunodeficiency. So is the fact that this patient was on Xeljanz to blame for her infections? And for that, I'm just reviewing some of the clinical trial data and the results when Xeljanz was approved. I'm sorry, there's a lot of questions coming through. Do you want me to pause?
So maybe if you go back a little bit just before you go into the review to the questions on the labs and so on might be a good idea. And whether I don't know if we know any of her previous treatment prior to this, but
we know that she was on Humira before for about 6 months, and then she was switched to Xeljanz for about 1.5 years.
And I guess there's a question if the Th17 cells were done, but it looks like it's not on the flow that you have.
No, it was not.
And then there's a question on the TCR rearrangement.
I'm not seeing it.
The question is there only a single T cell receptor rearrangement? And was it antibody or GD? I'm not sure I knew what GD is. There's also a question of was CD62L shedding on neutrophils in view of the UNC93? And then there's another question that you mentioned the Aicardi-Gutierrez gene, and was her variant suspicious for being pathogenic, and did you get her interferon signature? Oh, sorry, alpha beta. That was obvious. I should have done that. So yeah, it was alpha beta or gamma delta on the T cells. Sorry, that was a lot of information all at once. But if any of those, I'm not sure how much of this you were able to get, but if any of it was available.
I don't think so. Dr. Ramesh, do you remember for the T cell receptor gene rearrangement?
It's a PCR-based assay and it's alpha beta. They don't. This is the routine one the hospital has. Does not include gamma delta, and most of the other questions about further workup like interferon signature and other things, Th17 cells, we were not able to send. It essentially ended at our workup was had to stop right at this point because of the pandemic.
Okay, should I go on this next slide?
Yeah, and then we'll have more discussion.
Okay.
But let's let you get forward.
Okay. So tofacitinib inhibited on the acute lipopolysaccharide-induced inflammatory response in a murine model of innate immunity, which is dependent upon interferon gamma and STAT1. Dosed at 5 milligrams per kg, it inhibited TNF and IL-6 reduction, while the production of the anti-inflammatory cytokine IL-10 was enhanced. These results were interpreted as consistent with inhibition of interferon gamma signaling by tofacitinib through blockade of JAK1. In studies of the adaptive immune response, specifically the differentiation of T helper cells, tofacitinib blocked the differentiation of type 1 T helper cells and type 2 T helper cells and interfered with the generation of pathogenic type 17 T helper cells. Common adverse events observed during the trial was nasopharyngitis, upper respiratory tract infections, headaches, diarrhea, and the most common serious infections were pneumonia, cellulitis, herpes zoster, and urinary tract infection. Malignancies included lymphoma and GI perforation have also been reported in patients receiving tofacitinib. Changes in safety laboratory test values included increases in high-density lipoprotein, low-density lipoprotein, total cholesterol, serum creatinine, and liver transaminases. So just some more comments on the other cell lines. So neutrophils, moderate decreases in neutrophils are expected with efficacious rheumatoid arthritis treatment. Dose response plots indicated that changes in CD3, CD4, and CD8 counts were small and variable with no consistent dose response patterns across studies. In contrast, the natural killer cell counts showed dose-dependent decreases Model-based characterization of NK cell counts indicated that reductions were predicted to reach nadir by 8 to 10 weeks after initiation of treatment, with approximately 36 and 47% peak mean reduction for 5 and 10 milligram doses, respectively. Based on the pharmacological properties, T-cell mediated immunity may be altered by inhibiting cytokine signaling required for T-cell development and T-cell function after antigen stimulation. T-cell development is minimally altered in most patients based on the finding that circulating T-cell counts showed little change with short-term treatment and decreased by less than 20% on average with long-term treatment. This moderate decrease in T-cell counts precluded a definitive assessment of reversible after drug discontinuation. And then B-cell counts showed dose-dependent increases in all studies. The mechanism and clinical significance of increasing circulating B-cells numbers in response to JAK inhibitors are unclear, but we know that humans with JAK3 deficiencies also have increased numbers of circulating B cells, but are accompanied by severe reductions in serum immunoglobulin levels. So this was not the case with our patient, right? Her B cell counts were not increased, they were non-existent. And then with tofacitinib, you can expect some decrease in serum immunoglobulin, but not as significant as what we saw in our patient. So overall, reviewing all of these trials and data on tofacitinib, it became clear that this was not the reason for why the patient's labs and her clinical history for why it was occurring, and it became more clear to us that Xeljanz was not to blame. So next steps, so thoughts on final diagnosis, and this is obviously a point of discussion, and this is why we're presenting this case. We think that she likely did have a B-cell immunodeficiency prior to start of immunosuppressant that only presented itself later in life, or while she was, while her disease was not well controlled. But given her low immunoglobulins, the fact that she had no protective strep pneumotiters and her recurrent pneumonias, the next appropriate step was to start her own replacement IVIG, which we are doing. And then we are considering further steps of what we should test her to next. And before I open it to discussions and comments by Dr. Cunningham-Rundles, I also wanted to bring to attention that our the Invitae panel for primary immunodeficiency, they only test 207 genes. So there is other possibilities out there that have not fully been explored of that could explain our patient's picture. So maybe a possible CVID phenotype. I mean, she has low immunoglobulins, no B cells, and elevated T cells. Is this a patient that has Icahn deficiency? It was one of the thoughts that we had. For that, we maybe possibly need whole exome sequencing. But I'm going to stop right there. And I just included the Invitae results in case anyone had more detailed questions about that. But I'm going to stop right there, and I'll leave it to Dr. Ramesh and Dr. Cunningham-Rundles to make any further comments.
So Manish, go ahead.
So I just wanted to mention about her. She does not have, so there was lots of questions about hyper IgE. She doesn't have any of the other features that we would expect with autosomal dominant hyper IgE, for example. We also don't see, and her history of infections is remarkably limited to that period after she was put on immunosuppression. So our opinion is that she had sort of this B-cell immunodeficiency that was all along there, and adding on top of that these immunosuppressant essentially broke the second leg of the immune system and turned her functionally into skid, and she started developing all these problems. it's to me what was always very surprising was how did they come to the diagnosis of rheumatoid arthritis. Now, to give you background on her, she doesn't, we practice in New York City, but she lives in and around New York City, but she actually lives an hour and a half away from here. They go to a community hospital, and her rheumatologist is a private practice rheumatologist. Um, and to complicate everything, the only sign out we got was a brief phone call with the infectious disease doctor. After we got workup, it turned out the infectious disease doctor who was supplying us with information left the center, and so it's a usual sort of mess of trying to get all the information that we need. But mom's very on top, and so the history that we have, or the lack of history of infectious disease prior to this point, this year and a half, 2 years prior to presentation, was very clear. Mom is very clear. She never had any abscesses. She never had any dental problems, other than these joint issues, which sounds like were clinically done. She did have some blood work. We don't have results of that. There was a question about whether she had an immune deficiency workup before she was started on the rheumatoid drugs. To our knowledge, there isn't any workup. The infectious disease doctor I spoke with said she didn't have any baseline immunoglobulins. I didn't. We did not get, for example, and did anyone check an RA factor? Did anyone check anti-CCP? So all of those things are really quite missing. Did she, regarding her neurological issues, again, we talked to her. So her sister actually has seizure disorder, or had seizure disorder as a child, but has normal mental status. Her sister has maybe has um, some sort of phenotype of ADHD versus autism that is also there, but is does not have mental retardation. She has normal mental acuity, is full functioning. She Our patient doesn't have any facies as such. She doesn't have any neurological deficits that we know of. And I asked mom if she had a neurological evaluation. She said she had some neurological evaluation at the time when she was an infant. Along with the genetics and stuff that, not in genetics, but the so when they were assessing what her learning ability was, but it was a cursory exam. She's not had any neurological findings since then, and there was nothing to remark about until this first the rheumatoid arthritis and so on. And then we were also curious once the Icahn came back whether she had any lupus-like features, and essentially she doesn't. At the time when we saw her, she really doesn't have like inflamed, very active joints that you would expect with someone who has poorly controlled rheumatoid. And keep in mind that she was off immunosuppressants by the time we saw her, so they stopped immunosuppressants as I said to her, but she hasn't in the last, I would say, less than a year that we've known her, had any flares that we know about. Was there anything I missed in terms of questions? CT scan of lungs. We don't have a recent CT scan of lungs. We had one when she had pneumonia, or we had heard about the report from when she had pneumonia. Essentially said she had pneumonia, but that's about it. She was supposed to get a new scan to see what her current status was, but we don't have that. Edith, did I miss anything?
I don't think we did. Dr. King had an interesting comment, which I think we're seeing a little bit more of. We all know about Rituxan and possibly unmasking a immunodeficiency, or at least we know there are people who never recover from Rituxan. There's a question with these other rheumatologic drugs whether that may happen more, and as more and more come on the market and more are used, are we going to be seeing more of this happening? I think that's an interesting question.
So there's two parts to that. So one is, first of all, she did not get Rituxan to our knowledge. We did ask, and we also tried to ask in terms of how she got the infusion, try to sort of ask if mom didn't know that she got Rituxan, but we asked Was there an infusion? Like, did you get for so many hours? She got pre-medication. We tried to finagle it that way, but didn't really get anything that sounded like she got Rituxan. Now, the second thing is that as far as the other drugs are concerned, or even for that matter for Rituxan, yes, persistent hemoglobinuria has been reported, but B cell aplasia, to my knowledge, has not been reported with a biologic. I don't know if anyone else on this wants to comment that if they have, um, if there has been any reports of complete B cell aplasia with a biologic.
The problem with that is that a lot of people using Rituxan are not testing anything in advance. So I think we don't know the answer to that probably.
There was also a question about I think I missed this about karyotyping. So to our knowledge, she has not had karyotyping, or if she has had karyotyping, nothing was reported from when she was a kid. She has not had recent workup, and we don't have any of her labs and stuff. As you heard from President, she's 29, so we don't have anything from when she was 2, 3, 4 years old, and mom doesn't have it.
So I think there's a lot more discussion, and I think it's really interesting discussion, and maybe we can keep some of these if we have time at the end, or perhaps we will send them on to Dr. Cosper and Dr. Ramesh to look at, because there are great suggestions in here, and part of this was a discussion of where to go next with this. But I did see that Terry Harville wrote in that they're submitting an abstract for Quad AI regarding rheumatologic treatments and the unmasking of primary immunodeficiency. So I think we'll all be very interested in reading that. So with that, I think to be fair on time, we should pass over to the next group, and maybe we'll have more time at the end to discuss more.
Are you done with discussion on this particular case?
Yeah, I think we'll hold here and have the next case, because we're already past the half hour.
Right. The only catch is that I think one of the diagnoses that would be standing out for me has not been discussed.
Oh, well, let's go for it.
Well, that would be Kabuki syndrome. This one is a dead ringer for Kabuki, actually. And I thought that's what you were going to possibly get to. The other thing, did she have calcifications in her brain? And the Kabuki gene is not listed on the newest, on the previous InVitae, and now it currently is. And NF-kappa B1 and TCF3, which obliterate your B cells, is not listed as well on the InVitae panel that you did. It's included now, but it wasn't included when you ordered it. So you're missing, I think, 2 major genes right now, and Kabuki to me would be sort of fitting everything together. Several people here are noticing, the rheumatologic side has been left out. She's 29 years old. She's at home with her mom. Her mom is answering for her. And she turns out to be quite immune deficient, which was a surprise and a shock to everybody. And that's pretty much the way Kabuki looks. We have quite a few Kabuki adults who are extremely immune deficient exactly this way. So to me, I would have gone for that diagnosis here as my first thought. And the other thing, if you wanted to know any more about that 8-Cartier-Gutierrez gene, what about an alpha interferon in the serum? And number 1, and number 2, if you really wanted to know about it, it's right at the junction of the helicase 1 and 2 domain of that particular gene. And so the ones in either helicase domain around it have been reported to be associated with 8-Cartier-Gutierrez, and you don't have to have a lot of physical signs of it. In fact, you can have late presentation. Even carriers don't even have to show it, according to the paper by Yannick Crow. So if you wanted to know whether that's the case, she would have to be off the Xeljanz, of course, but then she could be tested by Dusan Bogunovich, who can test that cycle for you. And he's at Mount Sinai. And you can also get an alpha interferon in the serum. Quest actually runs it.
A question, Charlotte, about the kabuki. How often is the facies associated with the
I would say
phenotype?
not. If you look online and look at kabuki, you would be completely misled by what it's supposed to look like. Our adults don't look that way. They just look like normal, everyday adults. With the arched eyebrows and the rest. It's kind of it's misleading. So that's my
Thank
capsule.
you. We will be sending the work up for those.
Okay.
It's very interesting to know about the kabuki because previous presentations we'd heard about facies and other things.
No, forget it. Just forget it. It just doesn't look that way for adults.
That is good to know.
All right, that was a great discussion and very intriguing case. Thank you. Thank you, everyone. I'm Nikita Raje. I'm from Assistant Professor of Allergy Immunology at Children's Mercy Hospital in Kansas City. And today's case will be presented by Dr. Marissa Love. She is an assistant professor of internal medicine at University of Kansas Health Systems, and she'll be presenting a case on asymptomatic T-cell lymphopenia in an infant. So changing gears here. And our senior mentor today is Dr. Troy Torgerson. Again, he is our second mentor for the day, again, who does not need any introduction. He's the CIS president and is from Ellen Institute. So Dr. Love, are you ready?
I am. Thank you.
Right.
Okay, so our case is in regards to an 11-day-old asymptomatic term infant who was urgently referred to our hospital by their pediatrician due to severe lymphocytopenia that was found after a history of 2 abnormal newborn screens for T-cell receptor excision circles. In regards to the actual results on the newborn screening, her quantification cycle for TREX was greater than 35, and our cutoff for referral is greater than or equal to 34.62. In addition, her quantification cycle for RNase P was 22.22. Our cutoff in the state of Kansas is anything less than 26.68 should be as part of the referral. Her outside labs that were done locally showed a total lymphocyte count of 2,120 cells. Oh, I apologize. This is a female infant, Caucasian female. Her CD3 T cells were low at 79. The T helper cells were 74. Cytotoxic T cells were absent. In addition, the naive T helper cells were also absent. Her memory T helper cells were low at 48. Her naive cytotoxic T cells were absent, and then memory cytotoxic T cells were also absent. Her B cells were within normal range, and her NK cells were a little bit above the normal reference range. And all of these labs were taken at a local lab at 9 days of age. So in regards to the history in the newborn period, she was born at term at 39 and 1 weeks by vaginal delivery. There were no complications. She presented without any symptoms right at birth, and so she did receive hepatitis B vaccine, erythromycin ointment, and vitamin K. Her birth weight was 6 pounds and 6 ounces. In kilos, that's about 2.9 kilos. And then maternal labs was pretty routine. Mom was rubella immune, negative for HIV, hepatitis B, syphilis, gonorrhea, and chlamydia. Mom was positive for GBS, and she was appropriately treated prior to the delivery. Mom was also CMV IgG positive, and I'll talk about a little bit about this later. So she did get breast milk initially without knowledge of their newborn screening results, and then was quickly transitioned to cow's milk formula once they found out. In regards to family history for this infant, there was no history of immunodeficiency that had been formally diagnosed, no history of thymic defects in the family, no maternal history of HIV, no family history of consanguinity. Everyone in the family received appropriate vaccines prior to the delivery of the infant. So we saw this patient at 11 days old, and in regards to the exam, there were no abnormal facies, and actually there's a slight typo here. The tonsils, I did not visualize the tonsils, so not present. There's no lymphadenopathy. And there was a normal heart rate with no murmurs. Lungs were clear auscultation, no organomegaly, no rashes, and she did have normal appearing skin, nails, and hair. In regards to the question about immunosuppression for GBS, she had just received the routine antibiotic about 4 hours prior to delivery, within 4 hours prior to delivery. And so I was going to stop here and just kind of gather your thoughts on initial differential for possible diagnoses. Yeah, I see some IL-7 receptor SCID related deficiency.
So definitely a possibility. What else? George does not have to be dysmorphic. Greed. CODO1A. FOXN1. TBK. Infant of diabetic mothers. All great thoughts. Congenital CMV. Okay. All right.
Yeah, that was all great. And kind of along the line, same things that we were thinking, possible severe combined immunodeficiency with T minus B plus NK positive cells, IL-7 receptor deficiency, deficiencies of the CD3 subunits, delta, epsilon, or zeta, also LAT deficiency. In addition, thymic defects such as complete DeGeorge syndrome, and then of course some of the retroviral infections, acute versus chronic, HIV being the main one. So in regards to additional workup, so for the infant, serology that was done looked primarily at CMV for antibody levels, as well as PCR testing for CMV, adenovirus, EBV, herpes virus 6, HSV, and then we also did HIV screening. All of that was negative for the infant. And as you recall, for the mother, she only tested positive on IgG antibody to CMV. The rest of her viral testing did not show any active infection. We did ask the mother not to give any breast milk, and as you recall, we had her switch over to formula fairly quickly to prevent any concern of reactivation of CMV and then risk of infant developing disseminated CMV. Additional workup for the infant did include a chest x-ray. So we're an adult, primarily adult institution with a pediatric unit. So this chest x-ray was initially read as normal at 11 days old. When I reviewed it again with the radiologist, they took a closer look and thought that perhaps given the patient's age and her term delivery, she should have had a more prominent sail sign, and they thought that she had a narrowed mediastinum as well as a smaller thymus than expected for her age. We did go ahead and obtain an echocardiogram, and it just showed a typical patent foramen ovale. And then fluorescent in situ hybridization was obtained for 22q11.2 deletions, and that was normal. All right, and then the next set of slides, sorry, is a little bit smaller than I had anticipated. So this was her lymphocyte studies. And the first column here were the outside labs. The second column, day of life 14, did show that she had low CD3 counts, low CD4 counts, CD3 count of 121, CD4 count of 113. The CD8 count was 8. She had slightly lower level of CD19 counts and a normal NK cell count. And over time, in the initial hospitalization, she has continued to have low CD3, CD4, CD8 counts, and then her CD19 count for the B cells did normalize within the normal reference range, and then the NK cells they had continued to stay normal. Lymphocyte proliferation studies were obtained at 11 days old. It was a little bit tricky because the lymphocyte proliferation studies to the mitogens, the viability of the lymphocytes when it was received was low. However, the way the final read was from the pathologist was that it was moderately decreased CD45 total lymphocyte proliferative response to PHA. However, the CD3 positive T cell response to PHA was normal, and therefore overall the PHA response could be considered to be normal. She did have normal CD45 total lymphocyte and CD3 T cell proliferative responses, and a moderately decreased CD19 B cell proliferative response to antigen. In regards to the lymphocyte proliferation studies to antigens, it was sent, however, the sample was insufficient, so we were not able to get any results from that. The same set of studies was repeated again at 10 months old, and the viability of this study actually that's an error there, but the viability was normal, so it was a trustworthy lab. It did show moderately decreased CD4 total lymphocyte proliferative response to PHA, however, the CD3 T cell response to PHA was normal, and therefore, again, they said that the overall response to PHA could be considered to be normal. And then similar findings for pokeweed mitogen, mainly that it was moderately decreased CD19 B cell proliferative response to pokematagen. The proliferation studies to the antigens were also done. She had a normal lymphocyte proliferative response to Candida. However, she did have an absent CD45 total lymphocyte and CD3 T cell proliferative response to tetanus toxoid. For our patient, she never was vaccinated to tetanus toxoid. And that is right here, sorry. Okay. Additionally, we did look at her IgG levels as well as other antibody levels. She initially had a normal IgG level at in the first few weeks of life, which we had presumed to be related to mom's antibody levels that crossed over in the third trimester. However, it did start to wane within the first few weeks, and so we did go ahead and start her on subcutaneous immunoglobulin infusions. There was a question here, sorry I missed it, about what was the reason why she wasn't vaccinated. It was thought that perhaps since she didn't have a significant number of T cells and have very low T cells, that she wouldn't respond to vaccines and make antibodies. And then, of course, we were avoiding live viral vaccines because of concern of disseminated viral infection given her low T cells. So this patient was hospitalized. In that initial hospitalization, she was placed under strict isolation precautions in our NICU unit, and then underwent all of this workup. As per recommendation through infectious disease, she was started on several antimicrobial prophylaxis agents, including acyclovir, fluconazole, trimethoprim, sulfamethoxazole, azithromycin, and then we started her on subcutaneous IgG infusion. She was born right at the start of fall, and so we were worried about possible RSV infection, so we did go ahead and give her palivizumab monthly during the winter season. And yeah, there's some great questions in here, and so I'm just about getting to some of the additional genetic testing here. At this point, though, let me just take a quick break and see if there were any other questions or thoughts about diagnoses.
So there were a few comments that maybe you already addressed. Looks like, the question about tonsils. So yeah, that tonsils were absent. There is a suggestion of using microarray in place of FISH for 22q. Another vote for Coro1A deficiency. You already answered for vaccines. And then, yep, we are back to our discussion about the panel of genes.
Yeah. We did genetic testing also through Invitae. At the time, we had chosen the primary immunodeficiency panel with the combined immunodeficiency gene panel. So these were all of the genes that we tested for. It came out to about 86 genes. And it did include IL-7 receptor gene, as well as the CD3 subunits. It did not at the time include the gene for LAT deficiency. It did include several of the defects for T minus B plus NK plus SCID. Otherwise, such as like the CD45 deficiency. And so the next slide shows what her genetic test results were. And we had collected this through when she was in the hospital towards the end of her initial hospitalization. So she tested positive for a single point mutation in FOXN1. It was described as a variant with a sequence change that replaced histidine with tyrosine at codon 321 of the FOXN1 protein. Additionally, we also tested the family, and both her mother and father had genetic testing with the same panel. The mother didn't have any abnormalities. However, the father has the same exact mutation. Interestingly, the father, although he'd never been diagnosed with immunodeficiency, going back to the parents, so no phenotypic features with the parents. They seem to be pretty healthy 30-year-old Caucasian adults. So the father's clinical course, even though he had never been diagnosed with immunodeficiency, he did have pretty severe disseminated varicella that required hospitalization for a couple of weeks, around the age of 7. And later in childhood, he remembered that he was hospitalized for staphylococcal abscess, as well as strep impetigo that required IV antibiotics. As an adult, he had reported viral upper respiratory infections about 1 to 2 times per year, but did not have any other hospitalizations. And the father did not have any skin abnormalities. So the father's immune evaluation, in regards to his immunoglobulin levels, he was normal, and he had adequate protection to tetanus toxoid, diphtheria toxoid, as well as some of the viruses that he was vaccinated for. Interestingly, he was not protected against varicella. He had a low baseline protection to strep pneumonia. His lymphocyte subsets panel, I'll just kind of skip to it in the bottom here. He had a low CD4 count, 269 cells, but the rest of his subsets were normal, and then his proliferation studies were normal.
So one of the questions was the father's genetic testing was the variant in heterozygous state.
Correct.
Okay.
So as you already know, FOXN1 is critical to thymic development. Homozygous FOXN1 mutations have been described. And then recently, heterozygous mutations have been described, but they're not as well defined as the homozygous mutations. Apologize here. So I really like these figures, and I have the references all the way at the end, but just kind of describing the homozygous mutations that have been reported on the top bar here, as well as the heterozygous mutations in the middle section. And in regards to homozygous defects, it was initially described in 2 sisters, and the classic symptomatology included alopecia, nail dystrophy, plus severe infections related to a T-cell immunodeficiency, typically due to low CD4 T-cells. Now, Dr. Notarangelo's group, and this is the study that I was referring to, had recently published a study looking at 47 patients, looking at infants and adults that had heterozygous FOXN1 variants. And in the infants, had a very similar presentation. The one difference with my patient is that she did not have any nail dystrophy. And then my adult patient did not have any skin, hair, or nail abnormalities either. and his CD4 count was low, unlike the adult patients Dr. Notarangelo found, where primarily they had a CD8 T-cell lymphopenia. So going back to our patient, so over time, sorry, it's a little bit of a busy slide. Over time, her CD3, CD4, CD8 T cells have continued to be low. They're very slowly increasing with time, but they're very, very low. Her CD19 and her NK cells have been in the normal range for a while now. That was last done around 10 months of age. And this is just for completion. CD45RA T cells and RO T cells, the memory T cells, were looked at as well at 1.5 months and 5 months of age. So her clinical course, so she's pretty much been in kind of self-isolation ever since she was born. But at 6 months, she did develop a rash that seemed to be somewhat responsive to antihistamines, and then resolved over the course of 2 to 3 weeks with antihistamines and some topical ointments. And then around 7 months of age, she did have 2 separate courses of what was presumed to be viral gastroenteritis. However, her lab evaluation was negative for stool cultures, O&P, and then did not have anything show up on the respiratory viral panel. At 8 months of age, she had acute otitis media, and I should go back and say at 7 months of age, they didn't really do any targeted treatment for the second episode of viral gastroenteritis. So she did not receive any antivirals. In addition to her medications, she did not receive any antibiotics during her treatment or her hospital stay for that. At 8 months of age, she had a fever and was then diagnosed by the pediatrician for acute otitis media, and was transferred to our hospital and had a metapneumovirus infection, was empirically covered with ceftriaxone and just monitored for a couple of days and did well. She has had normal growth over time, and she has had a normal weight and normal height. Developmentally is appropriate for her age. She's been continued on subcutaneous immunoglobulin infusions. At 12 months of age, her IgG level was right around 1,000 on subcutaneous immunoglobulin infusions. And then since COVID, the COVID pandemic had started, they've pretty much been in self-isolation. So this is kind of where we're at. Lab testing and evaluation on the genetic side of things were a little bit limited because she did develop some iatrogenic anemia due to all the lab draws we were getting initially. And so we've just mainly been monitoring the last several months now. But this is kind of our future steps and thoughts about where to go next, looking at FOXN1 studies, whole exome sequencing, further sequencing of the family, consideration for possible thymic versus stem cell transplant, and then just continuing to monitor her labs. And there's my references.
All right. One last question here. In the heterozygous state with normalish mitogens, would vaccination with live vaccines be contraindicated? And not sure if you want to comment on that. I know Dr. Torgerson was having some issues with logging in. If he's online, he could help us answer that question as well.
I'm on. Can you hear me?
Yeah.
Do you want to take a stab at that? What would you do, Marissa?
Yeah, so we actually just had been very conservative with giving vaccines, but I mean, Rachel brings up a very good point. And so, in practice, though, I'm not quite sure what the experts typically do in this situation.
What's one way that you could potentially test it to test at least the ability to make a productive antibody response and things like that that would be safe?
Are you referring to giving her pneumovax and seeing what her response is?
Or tetanus, or any other vaccine like that you could, where you can check titers, and if they
Right.
make if there's a really robust response, I mean, that's encouraging and would suggest that at least they can, that she can make a productive antibody response. Obviously, if the counts are too low, you do worry about a live viral vaccine. But there is literature related to T cell counts and susceptibility or risks with live viral vaccines, both from the DeGeorge literature and also from the HIV literature. And I think a lot of people will say an absolute CD4 count of 200 is often enough, but there's it's not, there's not a firm cutoff, but I think there is at least some literature to say at which point it's clearly probably safe. Do that. Did you have vaccine responses on her again? I apologize, I don't recall.
Yeah, so not initially. We did not obtain IgG to strep pneumo initially when she was born, or in the newborn period. We do have IgG to strep pneumo around 12 months of age, but as Dr. Cunningham-Rundles had already mentioned, she had already been on IgG infusions. And so, it may be difficult to assess her response unless we're using something, we're vaccinating her with something that's not available in the pooled IgG.
Yeah. And how long would you, I guess the other question is, how long would you leave her on IgG replacement? At what point would you take her off, or because obviously she wouldn't need live viral vaccines while she's on that.
Correct. Yeah. And yeah, going to your question, with her B cell counts being normal, certainly that's something we could take a look at and see if having her come off of IgG infusions is a possibility. And I did see that comment from, I think it was Dr. Bauer, was talking about Salmonella IgG pre and post. My understanding was that the lab in Wisconsin does that.
Yeah, and that's, it's a carbohydrate response, so it's a T cell independent response, and it would, it doesn't tell you much about whether your T cells are actually functioning as a problem, right. Because it's T cell independent. So, that's not maybe quite as helpful. We would have probably used, a different test vaccine, something like bacteriophagocytic 174, but that's not broadly available, and it's not, and there's not a lot of other great test vaccines that are where there's not going to be antibody in the pool. Some people have used rabies as a test vaccine, but I'm not sure that some folks might feel uncomfortable like giving it to a child this young. So it does make it difficult. I mean, this is a really interesting disease, and it does create a lot of, and especially when you consider it, when you look at the patient's father, who has done just fine, other than some early childhood, I guess elementary school age, had some issues with varicella, maybe, but overall has done reasonably well. And that was, I think, what, the adults that were studied in Gigi's paper that was published also, had done reasonably well. I think they were largely more consistently CD8 lymphopenic persistently than CD4 lymphopenic, and they over time had done fairly well, and the the FOXN1's been directly linked. FOXN1 and BMP sort of together as two transcription factors have been linked to thymic mass. In Gigi's paper, they look at the mice and show that the number of thymic epithelial cells are low, and that it particularly affects mice when they're early in life, and less so as they get older. And that is also, again, borne out in the humans, that it seems like this is a disease that's most difficult, most severe, most problematic when they're young, but as they get older, things get a little bit different, which certainly has implications for when you would pull the trigger. It's why making this diagnosis is really important. When you would pull the trigger for something like a thymic transplant, or you just hold out and wait and prophylax and wait until things get better. And I think that would be the course that probably most people would take if you know that this is the defect. And Manish put in I saw Manish in the chat said this amino acid lies right in the DNA binding domain, and there, even though this particular amino acid substitution has not been described as far as I could have been able to find in the literature, other amino acid substitutions at the same amino acid position have been described in the heterozygous state in these FOXN1 hets that are seemingly pathogenic. So it's certainly, and in this case, you'd have a replacement of a histidine, which has a relatively small, somewhat slightly positively charged side chain, with a big bulky phenol ring from the tyrosine that's going to be there, and so almost certainly, just structurally, that will probably create problems with the DNA, with the interface with DNA. So this I think, as Manish said in the chat, that's money, and I think he's absolutely right. I think it really is very, very, very likely that this is pathogenic, and that this is the cause of this child's T-cell lymphopenia.
Mm-hmm. That's great. Couple of more comments. Could one consider stopping immunoglobulin and start antibiotic prophylaxis? And the other one was, a comment saying that's a big reason why we should be waiting for the genetic testing before asking for a transplant.
Yeah. I mean, this case really illustrates why that's, with these tools we have available, why not wait? And especially since it's, overall, she's been doing quite well since being started on her prophylaxis.
Sounds good. Any final comments? I guess, I'm sorry, we are running a little late, so just want to make sure. Any other comments?
None from me.
All right. I know we typically present an article at the end. Dr. Schussler had worked on presenting an article, but because of the time issue, we are considering sending this the presentation or the slides out with the article in an email, if that's okay. All right. Well, thank you all for the two great cases. And you all have a good night.
Thank you all. Thank you for joining.
Thanks, everybody.